This is ASAP Pathway. Hi, ASAPers. Welcome back to another episode of ASAP Pathway, the podcast. I'm with you today, Dr. Stacy, and I'm honored that you, the listener, are tuning in again. And I'm really been working on getting my friend on that's coming on today for a while. Dr. Jackie Demko, welcome.
Thank you, Stacy. I'm finally excited to be here too.
I
Gosh, we've
know.
talked about this for years.
We sure have. So a little bit to the listener, a little background about Jackie. I'll just call you Jackie today. We're buddies sitting around
Yeah.
talking. Um, she is an orthodontist in my town, and we just organically just started talking and getting connected, probably because of our passion, our mutual passion, because for years we've been kind of beating this drum in the St. Louis area, and it just wasn't a very common, and it's still not
Yeah, it's not. I think there's two or three of us most doing it.
at the
More though.
most, right? And so I have her, I have a very specific, it's unfortunately a small list of orthodontists in my area that I know that if I refer to them, we're going to have a very collaborative discussion on the patient. We're going to do what's best together for their overall wellness. We are super respectful of, we agree on a lot of things, and maybe we don't agree on everything, but we're super supportive and respectful, and we learn from each other. And that's why I've always valued our not only professional relationship, but our personal relationship too. Because we talk about plenty of things when we're together that have nothing to do with any of this.
Nothing to do with it. Yeah. And I feel I've learned so much from you too. So it is so collaborative because neither of us there's no cookie cutter approach
Thank
to any
you.
of this airway stuff. And the more brains that are trying to solve the puzzle, the closer we get to the right answer.
Agreed, friend. Agreed. I'm going to introduce you. I'm going to read your bio. By the way, I told Jackie before we started, it's probably one of my favorite bios to read. Um, so here we go. Dr. Jacqueline Demko. She's not your typical orthodontist. She's built her practice on something pretty unique. The belief that when you optimize someone's airway, you're literally changing their entire life trajectory. And she's got the research background and clinical experience to back that up. What I love about Dr. Demko is she's not just jumping on the airway bandwagon. She's been diving deep into neuroplasticity, gut health, and systemic wellness for years, always asking the bigger question, how does what we do in the mouth affect everything else? Her patients don't just get straighter teeth. They get better oxygen flow, deeper sleep, improved cognitive function, and honestly, better overall health. But here's what really sets her apart. It's if there's a piece of the puzzle that she can't handle herself, she'll connect you with the absolute best person who can. She's become this incredible resource and advocate for her patients. She holds degrees from St. Mary's College, UMKC School of Dentistry, shout out to UMKC, and St. Louis University, where she conducted research on facial aesthetics. She's a regular speaker at conferences and study clubs, and she's actively involved in organizations like the American Association of Orthodontists and the World Federation of Orthodontists. But if you're really going to appreciate, what you're really going to appreciate about her, though, is how she thinks. It's not if we can solve complex airway and sleep issues, it's how we're going to make it happen. She welcomes the tough questions because, as she puts it, challenging cases make us all better. And it's so true. I love this, like I said, one of my favorite interests, but I just remembered how I first met you. I don't know if you're going to remember this because we both
Shoot.
went to UMKC Dental School. It was, I was looking for an apartment and I had just got accepted, and you were moving out of your apartment, and someone connected me and said, hey, there's somebody, her name's Jackie Demko. She's got an apartment. And that's how I literally first got connected with you. We never really developed a relationship, but that's how I first heard of
That's
Jackie
so
Demko.
crazy.
Yeah, it was the apartment. And I don't, what year did you graduate? UMKC.
94.
You were 94 from UMKC? Dental
No,
school?
wait, 98. 98.
Okay. Okay, that's because I'm like, I started in 98. So that's what it was. You
Oh,
were a
wow.
senior leaving, and
And
I was
it
a
was on the
freshman.
plaza.
Yeah, I was coming in, and it was your apartment. Holy cow, it literally hit me when I was
Oh
reading
my
this.
gosh. I don't never
Yeah.
hear that out before. That's crazy.
Yeah, that's how I
Did you
first.
move in that one?
No, I didn't wind up moving into your place. I never even, I just had all these apartments coming at me, but yours was the
Yeah.
very first one, and that's how I knew who you were. So then let's fast forward later in life. I get out of dental school, you've been an orthodontist. So like talk about your journey. Because you are in a long line of orthodontists. Let's talk about that a little bit. Like you're third
I'm
generation,
fourth
fourth.
generation dentist, second generation orthodontist. So my great grandfather was a dentist here in St. Louis, and then my grandfather on my mother's side, and then my dad was an orthodontist. And to be honest, like I struggled all through grade school, high school, I worked hard through college. I really had to scrap to get into dental school, and then a lot of it was because of my airway, which we can circle back into, but it's so amazing all the lights that have gone off in my head regarding, God, if I had that addressed earlier, that how much different things would have been. And so when I joined Dad, so I went to SLU, and that's a predominantly or was predominantly a tweed type education. Four buys on the floor is pretty much how you treat anything crowding or an overbite. And there was a few instructors that were like, "Nah, baby, you can do it this way. We'll do it this way." And but my dad wouldn't review cases with me all through my residency. And then when I graduated, because he always said, "When you get out, you just learn how to bend wire and move teeth, and when you get out, I'll teach you the right way."
I love it.
So the first thing I go into his office and he puts this model on the desk and he goes, "This is the finish. What did I do? Here's the start." And I looked at it and it was like a 10 millimeter overjet. And I go, "Well, you pulled teeth and did headgear." And he's like, "Nope." And I go, "Well, you did surgery then," because it was an adult. Scratch that. I'm not sure if it was an adult. He goes, "This is what I did." And he pulls out a bionator. And I had never seen one of those,
Oh
heard of one
yeah.
of those. And he'd been using them for years. In fact, he'd taken backlash from other orthodontists, like, "Why using that barbaric device on your patients?" But I'll tell you what, like, I see those patients bringing their grandkids into me now.
Wow.
And so that really was kind of the, wow, I can take what I learned and use my own brain and not just be focused on what the literature says, like you can't invade the canine space. And, after their final growth spurt, they're a non-grower and you can't influence width. And so I kept honest, candid conversations with people that fit on the fringe of what you were supposed to do and said, "Hey, I've seen some cases treated by other orthodontists with an expander, say a 55-year-old, and I'm willing to try it. I'm not promising anything. Worst case, we put it in, you pay me $100 for the appliance, and then we take it out. We'll keep a good eye on it." And that's just how I learned. And I found my own parameters on how late is too late to expand without splitting the suture and what it does to the buccal bone and what it doesn't do that we said it did. Um, and then probably a big thing was the NiTi expanders, which you've heard me talk a lot about. That
Yes.
I mean, I could not practice without them. But I also don't believe there's only one tool. And I've heard you talk about that on other podcasts. There's you got to look at each patient and what they want and what they need, and then you figure out the right tool or the right direction for them. And um, but
That's a
these
good
night
point, Jackie. Not even just what we think they need, but
yeah,
what are their expectations? What do they want? What are they even coming to you for? Because it's like you could say, "Oh, I see this, I see this, I see this." But the patient's like, "No, I literally am coming here because I have a gap between 8 and 9." Like it's what are their expectations? So valid.
yeah. I had a guy that came in last week that he had his front tooth knocked out, and he's 55, and he has edge to edge bite, clearly skeletal. He's midface deficient, has sleep apnea, has all these signs and symptoms, and he's not interested in fixing that. But my job, I feel, is to identify it, not overlook it, and then explain to him, okay, this could impact this your life this way. I'm here for you. Most of the time they end up coming back, maybe years later, but right now he would not have walked in my office had he not lost this tooth. So
Right.
that's his focus right now. So we'll see where it goes. He hasn't made a decision.
Yeah, but yet that's excellent, right? It's, just informing them and they have the autonomy to decide what they want to do with their own body. And sometimes you just plant seeds and they come back later. Um, let's circle back to your journey. So dad starts showing you like, okay, learn what you need to learn to get out of orthodontic school. Then I'm going to show you how to do it right. I think that's awesome. But and you mentioned if you would have had different tools growing up, breathing better, maybe describe. I have so much I want to jump into, so I'm kind of jumping around. So, okay, let's finish with your dad. Did your dad see wellness changes and things like that, or was that how did that all transpire? Why was he kind of breaking the paradigm and wanting you to do things different and think outside the box?
That's a good question. Um, so my research was on the Fibonacci ratio and facial aesthetics, and that is something that's hardwired in our limbic system. And so when I was doing my research, it was like I'm talking to dad about it, and he's like, duh. He knew it, but I don't think he knew it. But he was, as many of us in I think this profession are drawn to that symmetry and that balance. So yes, when he was looking at a profile of a collapsed lower jaw, he was going for aesthetic. Did
Yeah.
it open up the airway? Yeah, betcha on most of them. Advancing the jaw all the time doesn't, as we know, open. But yeah, and then he was huge. He had had teeth pulled as a child, and I think that, I mean, he was into expanders before, in my opinion, at least in the Midwest and what I saw other doctors talking about, not. Um, did he think it looked better? Yeah, but I don't remember him talking about the airway stuff, and it was not evident to me until I had one mom. This changed the way I offer expanders in my practice. I treated her two daughters. One was crowded and needed an expander. The other one didn't. She dentally, that's what I like to say, dentally did not need it. When I was done with both of them, she asked me why her one daughter's smile was beautiful and her other's wasn't. And it
Hmm.
broke my heart. And that was the last, and I retreated the girl. I put an expander in who had perfectly straight teeth, class one, and mom was so happy when we were done. But I realized then I'm not only going to offer expanders to people who are crowded, I'm going to offer them if they just want better buccal corridors, period.
Correct,
And
correct.
then that is when I started seeing biggest thing routinely seasonal allergies diminishing or going away. And I couldn't unsee it. I couldn't not get excited when I saw, oh, you kind of have not a great buccal corridor and you have seasonal allergies. How would you like to fix them both? And it was something I could almost guarantee. Like I didn't guarantee it, right? But
Right. You knew it was going to be a side effect of your expansion
yeah, and
more
these are the
often than
night
not.
high.
More often than not.
Yeah, yeah, for sure. And I think I was comfortable not just with the mindset of recommending or giving them the option. I always gave them the option because I would say you don't need this dentally. Here's the only reason or say 15 years ago, the only reason to do this is because you want increase in buccal corridor, you like that wide smile. And no one's coming to me. This is what I would disclosure. No one's coming to me to get their allergies fixed. But I'll tell you, I am definitely impacting them. But no one's lining up for me to do this expander to fix their allergies. And but because of the night high expander, no one had to crank it because that's a big thing that parents come in and they go, "Do I have to crank this?" Or, "Oh, I had one when I was a kid and I have to crank it." And that was scary. And it's not always scary. It doesn't have to be scary to crank it, but some parents just don't want to get in their kid's mouth. So
They really don't. Not a lot of them don't. Or let's just get real. the compliance isn't always
Oh,
there. They're busy, or they turn it the wrong way, or they think they're turning it a full
and
turn
they
and
missed
they
the
only turn
hole.
it at a fourth of a turn. It's just,
Yeah.
it can be a lot for some parents. I wanted to describe for the listener like what buccal corridor is. So what Dr. Jackie's talking about, when you smile, which I had four on the floor in good old St. Louis Orthodontics, um, I'm missing my first bicuspid. So when I smile, there is like a dark space between my teeth and my cheeks.
Let's
And
see if we
that's,
can compare. Yeah,
see,
so
see,
I'm filling mine just a little bit more. We're not a big difference, but
no,
yeah,
but
you can
I
see on
do
this
want you to
one.
widen me. And well, that's another conversation. But but yeah, I would like a wider buccal corridor. It's just cosmetic, but like what your dad said, or what you were saying about your dad, and then you said it's in our limbic system. Like we see, we recognize, like even children, they'll show a picture of the same person and say
Hmm.
which person is nicer or more attractive or whatever. It's identical, and they just may change, the symmetry a little bit. So
And then,
we're designed to identify that symmetry, the
yeah,
Fibonacci.
right out of the womb, newborn babies will stare always at if they have two pictures, the picture of the person who's more Fibonacci than the one that's not.
It's just in our DNA.
Just,
It's just
yeah,
so your dad was just seeing what, was more attractive. But like you said, you started to see changes. And I would love to visit what you're just talking about expansion. Um, as we both agree, there's no cookie cutter approach for any person. You walk into, our offices and we have to look at you as a whole person. We might say, okay, what's the diagnosis? Where are the deficiencies? Where can we help? Where do we need to collaborate? But at the end of the day, is what we're recommending something that the patient is comfortable with?
yeah,
Is what we're recommending something the patient is even going to be compliant with?
yeah,
Um, is it even what they want? So it all has to line up, expectations from the patient. So your point being, and a lot of the literature right now regarding any airway minded orthodontics, it's rapid palatal expansion, or it's like MARPI. So that is where there are TADs inserted, usually in the non-growing person. So it could be late teens, 12, 13, older than 12-ish years old. And definitely the adult, if you want to do expansion, everything is about MARPI, skeletal expansion. What makes you different is you are a believer in what works best in your hands and in your practice, and you feel the most comfortable with is not rapid palatal expansion. It is using Naitai springs, which are gently, kind of gradually expanding and like I guess sensing that give and take that the body is willing to move. Um,
hmm.
and that is your preferred source of expansion. So let's go into that. Why did you choose that almost 2 decades ago and never looked back?
Uh, so I was trained with the RPEs. Dad did RPEs. And I thought he was wackadoodle pushing the limit on doing it on a 30-year-old. He showed me his first 30-year-old that he did that on and broke the suture. And she remembers feeling the tension just release. So I get the whole concept of the MARPE and how it changed because at an older, I think they feel that
Yeah,
pop,
a
don't
lot
they?
of them do. They definitely do.
Yeah. And you get the big space, which you can manage now that people have figured out
Yes.
protocols with Invisalign. But honestly, the biggest thing was I'm just going to try this thing. That's how I've started any shift of something I hadn't done before is I'm just going to try this with this person or this person. And then my success is built up. And, Dr. Michael Williams is the one that invented the type I use. And I just would call him and I'd be like, go over this case with me. And but the hands down, it was because of the compliance. I wanted to set it, forget it. I wanted it smooth. I knew it was such a light, consistent force that it just made sense to me. Slow osteoclast, osteoblast, rebuilding. I found a lot of comfort in Dr. Boyd, a periodontist, had done a biopsy on the buccal bone. So this is, something dentists and orthodontists worry about is pushing the teeth through the bone if you don't split the palate. Well, we know that to not be true if you go slow enough. And I think Eunice talked about that, and some of the other ladies in ortho have acknowledged that. I think the RPE, like you said, is just used the most because that's what they're taught in school. And so
Right.
that's where most studies are. And I'm trying to do a study in my office. I mean, who has time? I've got 3 locations. I'm collecting the data, but do I have the right data? And who's going to process it? But Karen Parker Davidson is I'm getting the rhino manometer because I want to know how am I impacting the function of the nose where I have the rhinometer in my practice. So I know what I'm doing to the structure and I know I'm changing it in the positive
Yes.
way.
A
And
hundred.
the symptoms, which I think is the primary determining factor we should be using over any numbers, but I know my symptoms are resolving. I have people smelling for the first time and, you know, but a bunch of the other sleep disorder stuff going away. But I'm going to have the rhino manometer in to be able, she says that'll be helpful to be able to determine the function change.
Yeah, and something, Golly, I feel like every podcast I give a shout out to Karen Parker Davidson. I just did it in my last one too, so here we go again. But what is interesting and what we're excited about, she's going to be faculty too for ASAP. So we're really excited to have her education in there because I feel, Jackie, like you, it's a missing piece. We know we're seeing these anecdotally, patients will come back. I am smelling better, or I can see better. We hear people saying, I can hear better. I mean, you're just getting all these different cranial nerve
Yeah.
activations with expansion and orthopedics. But what is interesting about what she says is sometimes, especially with the rapid, it's like, when is enough, right? So
Hmm.
she's said, like you can actually expand too much. And now the nose is having to compensate, the body compensates in different ways because now you've increased the volume so much, you kind of miss the sweet spot. And
Yeah.
she's
Yeah.
like, there is
She
a
was telling me
sweet
about that.
spot. And because we all, have heard about that honeymoon period, whether it's tonsils and
Hmm.
adenoids, right? Tonsils and adenoids are coming out. Oh my gosh, my kid feels better.
Yeah.
6 months later, well, they're better, but some of the symptoms are coming back. Same
Oh.
with MARPE, or any expansion. Oh my gosh, I'm breathing so much better. And then months later, wait a second. And this is not in everybody. We just are hearing that this just happens.
Mm-hmm.
And this is part of her
Mm-hmm.
expertise is
Mm-hmm.
why does that happen in some people and not in others? Well, she is like, you're possibly over expanding, and that's the problem, and so now, because the body is just all about homeostasis and regulating what it
Yeah.
needs. So when the turbinates and how they flux, and what the tongue base might be doing, but the body's going to do what it needs to do to have just the right amount of airway resistance and turbulence. Like, there's a whole aerodynamics we're not looking at that she
Hmm.
is. And that's what you're
Yeah.
going to start getting into, is you're going to start diving into aerodynamics and
Yeah.
how your therapy affects it.
I didn't know that. She did mention that the other day, and I was like, like, dentally, I easily can grasp over expanding. In the sweet spot, yes, because I understand the pharyngometer and rhinometer. But the rebound, I haven't experienced yet, or I'm unaware that it's occurred. So that's really interesting. I'm going to pay more attention to that.
Well, and
And
maybe you're not experiencing, again, this is why we have these conversations. Why don't you experience that? So maybe you're not dealing with this overexpansion situation. I think I think what's interesting too, and a lot of people that are in the art, so we got all these camps,
Mhm.
listener, in our dental world, we have a lot of camps. There are orthodontists and dentists that just are like, we don't want to recognize, it's like, look over here. We don't want to talk about airway because it's going to change pretty much our whole paradigm. It's going to
Mhm.
change how I run my office.
Then
Um,
you have to question everything you've done in the past.
and there is fear in that. Like
That,
it. just to validate what someone might be experiencing, fear. David McCarty said that when you go up to a practitioner and you challenge their current paradigm,
Hmm.
that is very scary
It
for
is
a
very
practitioner.
scary.
It's scary because you also feel like, what have I missed? What did I do for the last 10, 20, 15, 30 years? What could I have done differently? And there's a lot of, I don't want to see that. That's uncomfortable.
And it's ego.
It's ego.
Yeah.
It
And
is. It
I've
is
never
ego.
had that mindset. I've always been like, oh, tell me more. Like what you just said about sweet spot. Okay, now I want to know more. What can I
Yeah.
do more to help? What can I, yeah. And that's what it's about. It's about learning. We're not gods. We don't have all the answers. We have to collaborate. We have to listen to patients and what is their experience. And if they rebound, they're going to tell us if we're listening. I would say just the past 2 years, I've really, as you know, gotten into the tonsils and adenoids. I feel totally comfortable diagnosing adenoids need to come out. And I guess I still say I'm not an ENT, but they're getting them out. So now I'd say now I'll probably get to hear because these kiddos are young that we're doing the adenoids out on. I'm going to follow them through the braces. So now I'm going to be looking for this experience of some rebound just from that. And that'll be because it's going to happen, I'm sure.
Yeah. I mean, well, and that's the other thing, and we say this in ASAP, I wouldn't want an ENT, my ENT colleagues sending me a referral telling me, hey, you need a crown number two. I would like you to blah, 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 telling me what to do in my profession. So I'm very careful how I refer to my ENT. I might see a huge adenoids. And in my head, I'm thinking, no brainer, get those suckers out, get out the adenoids. But I'm always like, please evaluate patients'
Hmm.
airway health, suspected enlarged adenoids. I mean, I can see them on the cone beam, but it's interesting, Jackie, you and I, we're in the same town. I
Hmm.
am going through, and you too, it's like we kind of hop finding these ENTs, finding good progressive ENTs that want to collaborate with dentists. And I just had the podcast that was launched today, Dr. Keith Matheny. He's an ENT in Dallas.
Oh.
And we were talking about like the collaboration wish list between dentists and ENTs because we share a playground. Like we overlap so much, And how do we better communicate? And what do they want? And what do we want? So, but his point was, he has a lot of ENT practices within his company, US ENT Partners.
Hmm.
And he said, not, it's kind of like when a new ENT practice might come in, not all ENTs are looking at sleep. They're not looking at, even they don't even all look at airway the same. They're all he said sometimes they just go, or if it is sleep, they're going straight into the throat. They're not looking so much at nasal valve and septal swell bodies. And so it's kind of even learning within our professions to speak the same language. We're just not doing that. Okay. I just want to I want to keep talking about your expansion technique a little bit. So you started just intuitively wanting to try this out, the slow progressive NiTi expansion. So it's basically something you said it earlier. You set it and forget it. You put it in, it's bonded. I know now you can they're casting them now instead of like the traditional bands. Now there's even cast, which is really cool, 3D printed banding that you could be doing to make it even an easier delivery.
Yeah, you can skip separators if you
You
want.
skip separators, like those aren't fun.
No.
And but you literally you bond it in and you forget it. And it just so describe to the listener, why do you like this so much? What about it? You sent me an article once because I started using like the Max 2000 series and I did love it. And parents love it
Good.
because I don't have to worry about it. But um just the difference, even like because some people will say, well, are you getting skeletal changes because you're not really like are you seeing that sutural split or most likely not because you're actually getting more, instead of like rapid palatal expansion, the suture, when they've done, histological slides of that area, it's more reparative cartilage. It's not necessarily new bone. It's more reparative cartilage, which is why you might see more of a relapse with that suture. Whereas with the slower expansion techniques, they're saying it's actual like bone changes happening in that suture, which is why you're not going to see radiographically. I just wanted to hear what
Mm.
you think and feel about it.
And that's all it would be is what I'm thinking and feeling. And yeah, I remember sending you that. Wasn't that was
Yeah,
a
it's a
good
very cool
article. I
article.
tried to pull it out to read it again because
It's good.
once
It's a good one.
once once I read it, I was like, okay, I felt validated and I moved on. Um, but you brought up something that I think is why I most feel I get a good result and it's stable is it's slow, so the musculature has time to respond. When you do anything rapid, you think about diet, exercise, there's rebound, there's more rebound. But if you do it slow and consistent, like if we diet and we're slow and consistent, we're gonna have better skin rebound,
True.
tightness than if we,
Elasticity.
yeah,
Yeah,
yeah.
true.
So even in my early surgical cases, I would have adults come in that needed, say, a lower jaw advancement. I would condition their muscles with a twin block because if you break a jaw and slide it forward, that muscle is a rubber band to pull it back. And my first case, I didn't do that. I was so disappointed. I was pumped for this man to look like he had this chiseled jawline. And I fixed his bite, but this didn't look much different. And it was probably 4 or 5 millimeters. I felt it should have looked more significant. So, and I thought, well, why? It had to be the muscle. And when I spoke to the oral surgeon, he's like, yeah, there's always some rebound. And I'm like, I don't want that rebound. I want less. And I want to know ahead of time. So I think that slow concept because timeline. So on a 7-year-old, I'll put a max 2000 in and I've had some be done in 2 weeks. I always bring them back at least a month or 3 months. So 1 to 3 months. The older they get, so up to like our age, if we put it in your mouth, I'm going to tell you plan on 9 months to a year. It just takes longer for that bone to just turn over. But as far as what's going on at the suture, I don't know.
Right.
Cellular,
That article isn't, that's the only thing I've seen. And I think that's the
it,
call out is, boy, it would be interesting if we could have a little more research on what is happening and take what's happening anecdotally in your practice and validate it. Like this would be fantastic because you're not the only one. There's plenty of people out there
do we have to
that believe.
biopsy it? Do we have to CBCT? I mean, that's not
Well, I think in this article, which, gosh dang it, I have to figure out what article this is when we post the
me
podcast
too,
because
yeah.
someone's going to want to see the article that we're
Yeah.
talking
Okay, I'll
about. Do
find it
you
too.
have it? Because I had
I saved it. I just couldn't find it quick enough last night.
okay, so we'll have to get this article. It was interesting. And again, I think it is in full disclosure, I think it was written by the person that possibly that invented
Design
the,
designed it. I did
I
have one
think.
from Williams and Boyd that they wrote, but I think I also not the comparison of RPE. I sent you that one, right?
I don't know that you sent me that one. I just had the one that was, and no, maybe it was the comparison, I
I found
think.
some good research on the MARPE versus RPE versus the NITI comparison in terms of how much nasal change you could get. And
Okay, now that I want to see. That would be really good if you could find that.
yeah, yeah,
That would
I'll
be
send it over.
fantastic. Because I mean, that is, there was an article that was just pushed out in the Atlantic last week. And, it's an orthodontist that thinks, oh, this whole airway thing, it's absolutely nonsense with orthodontics. Like, this is not something we should even be doing and, then, there was another orthodontist that was like, there's more for us to learn. Um, Definitely address the cosmetic aspects of it. It was more about why are we putting so many expanders in children and of course, the bend, the angle, like the title of it was basically, Are we wrenching children's mouths open? Like, wow, that really sets the tone for the article, right? Like,
What a disservice to the public to have that out there. But it's not an invalid question. But I strongly believe that the answer is because of how we eat, because we eat and what our tongue doesn't do.
this
So,
just became an explicit podcast. I love it.
I
This
mean,
is how we talk, though, when we're together. Okay,
right.
let's
I'm
go to
sure you
that.
read the book by James Nestor. We talked
Oh,
about
yeah,
that, right?
breathe.
Yeah.
He's
I
so good.
mean, since industrialization, we don't eat the diet that we used to. So we don't use our jaws. They don't develop like they used to, like they need to for our whole airway to work. And then we can't breathe. I've been developing this AI practice management software.
I saw that. So
Oh,
let's go into that because, like, look, I'm looking at this, and you said, "How am I tracking this? How am I tracking all of this anecdotal experience that I'm having?" And it's like you've built an AI system that processes every consultation. It
yeah.
extracts symptoms, concerns, and treatment discussions, and then you can query it. It's like, how
Yeah.
often do patients report grinding? What is the most common symptom profile? You're running continuous practice-based research without disrupting clinical workflow. What the heck? Let's talk
Yeah.
about your AI. What?
That I Yeah, so I just ran one because I go, I'm getting on this podcast. I want to have something. So the past month, it's only been live for a month. 30% of my consultations I've referred out for tongue release. 30% in myofunctional therapy. So that's a lot.
That is a lot.
My
That's
staff goes, I'm
significant.
surprised that's so little because they feel like it's more. But and I mean, it's all because of the way we're eating. Well, in the MTHFR gene,
Yeah, there's
we
all of that. There's in utero, there's genes, there's
hmm
the genetics, the epigenetics,
hmm
our environment. There's so much. Sometimes, Jackie, it feels like so much has to
hmm
change, and you feel like you're this uphill climb. And I think too, this is the issue. Okay, are there people in our profession that are on one extreme, of course, that don't think we should be looking at any of this airway talk, stick your head in the sand, nothing to see over here, don't look behind the curtain. Yeah, they are.
Yeah, I don't get it. Like David Sarver, one of my favorite, most published orthodontists, at a lecture 2 years ago goes, expanding doesn't change airways. Dude, I don't know how you practice orthodontics for 50 whatever years you've been practicing, and you don't know that because you can't not see it. You can't not see it.
You're right. Well, I mean, what are they? Do
Maybe
they
he's not
have?
expanding. And
I
he's
don't
all about
know.
aesthetics. And I was listening to a podcast you did where it's so true. A lot of times the good airway happens because you followed the aesthetics, because it's that whole Fibonacci thing. If you have a balanced face, balanced profile, balanced arches,
That was Rebecca Backow.
yeah.
Yeah, it
And
was
this
Rebecca Backow.
and the Spear Group, the other guy, the
Yes,
surgeon
yes,
from Spear Group.
yes.
It's so true.
Gunson, Michael Gunson, the oral
And I think,
surgeon.
yeah, yeah. And I think that's what my dad did. He followed aesthetics. I followed aesthetics. And then you can't not see the airway. And Sarver follows the aesthetics. So, David, I challenge you. Like,
All right, hashtag David.
and maybe
Let's have
he's
a
changed his
conversation.
mind.
Maybe we have David on sometime and go, what the heck?
Yeah, yeah, yeah. And he probably would.
It
And
would
I
be fun.
think
That would be fun. You know
it
what? That
can
would be fun because here, this is it. Can we just have conversations respectfully with each other with a cup of coffee and like literally hear where people are coming from and not have these ad hominem attacks and like golly, some of these
it just all comes from a place
write-ups.
of fear,
It
and it's
is from fear. Oh, it's like you're challenging me and I'm gonna come out guns a-blazing. It's like, why? That's not
yeah.
necessary and it's not helpful. Okay, so I was saying on one end, yeah, stick your head in the sand, or they're just like, whatever, you're making a whole lot about nothing. And then there is another extreme
Mm.
where I think people are obsessed with like intermolar width. And
Yes.
you know what I'm saying? Like
Oh my God, yeah.
they're like I don't have the intermolar width. They don't have this intermolar width. And it's like, okay, let's look at this human being. Not everybody should have the same intermolar width. That everybody doesn't need expansion. Like, not everybody
Yeah.
has an airway problem. I would
Yeah.
say a lot of people have airway problems, but
Yeah.
not
But
everybody.
not everybody. Yeah.
But there's just this happy medium, I think, where we all can flow and live. And
Hmm.
dang, it's just such an extreme. I'm like, oof, we got to just kind of land more in the middle and talk more about it. But shoot, okay, back to your AI. But this is like how all of our conversations go. So I'm just apologizing to the listeners. This is what it's like when Jackie and I go meet at Ruth's
They're probably
Chris.
following.
Yeah, we could get a steak, or we just sit in your
Yeah.
kitchen and eat some Dewey's pizza and have a glass of wine. Um, your AI, one, why did you feel this was necessary? Two, you just started about a month ago. What the heck? You developed this yourself? Like, what are you
No.
doing?
So I was thinking about this.
I mean, you don't have to give away all your secrets because I think this is pretty amazing. But
Yeah.
yeah, if this is proprietary stuff, I don't want to
It is
jeopardize anything.
proprietary, but I'll share what we started with that I know a lot of people are doing anyway, which is recording new patient exams. So
Yes, amen to that, guys. Love it.
we use Plod.
Me
There
too.
we just had a meeting with Plod, the
Did
company.
you?
Yeah,
I'm
they're
telling you right now, like shout out to Plod. Um, it is a game changer for your new patient consultations.
I mean, Stacy, I'll let you beta test this. It's like we're about there, and it's healthcare what we're doing. But so yeah, we're recording the new patient exam, and then it all stemmed from I'm just tired of running my practice. I don't want to babysit people anymore. I don't want to worry, did this get done? And we talked about it, but it never made it to your to-do list. So it's just all automated. And we've started with the new patient exam room and it tracks our conversion live. We have a dashboard live. So we know at the end of the day what our numbers were from that day, which to my knowledge, there's nothing like that out there.
Yeah.
But then we're also moving to the clinic where we're recording chairside. And the next step is to get the API so the documentation that was recorded will automatically go in our practice management software. So now I'm freeing up my people to actually speak to patients, to pay attention, to be engaged instead of worrying about typing or writing. So I'm going to have patients listen to, I'm going to have better symptoms. I'm going to understand, oh, what's really going on at home that they might need us to cheerlead for or whatnot. Just I feel like it's a way to give better customer service and well as me not have to feel like I have to manage and train people how to make a to-do list and make sure they follow up and then I have to monitor that they followed up and
Oh
you know,
gosh, Jackie, that is everything you're saying right there. That's like a whole
I
no,
know.
that's a separate podcast. Like I started Plod, actually Tracy gifted Michelle and I a Plod at Christmas a couple of years ago. She said game changer for new patient exams. So I started using it. I still don't have a way to integrate it into my software directly. So my associate and I, we open up Plod, we generate the version we like for our notes, then we have to email it to ourselves, then we copy it and paste it into Dentrix, which is still, I mean, I cannot tell you the amount of time. And then my team is not panicked about they
Oh
left
yeah.
out adenoids, they left out the referral, they left out my discussion about nasal rinsing, they left out the discussion about the orthopedic surgeon consults. I mean, there's so much that goes into it, but you're saying you're also using it for just like practice management stuff, which, wow, that's a whole other
And
conversation.
marketing. So
Mm,
yeah, so what better way to market your practice than to have an authentic message about what it really is like in your practice? Authentic testimonials that happen on the fly that are captured that you don't have to stop and so
that's
yeah.
brilliant. I've
Yeah.
always thought you're a smart cookie, but
It's
that's
just the ADD girl.
it is. It is. This is why I love our conversations because we both have. I
Well, and
mean,
we were talking, so I want to circle back to we were talking about the patient choice that they have
yeah.
say. And I believe both of us are somewhat spiritual. So when you think about there's I put pressure on myself to I want to fix you. I want you to have the best life moving forward. But sometimes we aren't meant to have the easy life. We're meant to have a lesson. So just because a patient doesn't choose to improve their airway when it could save their freaking life, not to have their airway addressed, to save their life, they choose the harder path. There's a reason, and it's something beyond what I can comprehend. And it's not them necessarily making the bad choice. Somebody else is in charge of their plan, and that's the way that's supposed to go. It might be that their daughter witnesses this and then becomes a health care advocate for other people in the
Yes.
future.
Yeah.
So,
That's a really good point is, geez, can we talk about that for a second? Like how much we put the onus. And I don't know if the culture of medicine is the same as dentistry. But in dentistry, there's this onus of like,
we fail if we don't fix them.
yes. So, and I don't know that like your average medical doctor might go through 4 or 5 different blood pressure medications before they regulate someone's blood pressure, right? And do they go home that night and go, oh my gosh, I'm on the fourth blood pressure medication. Why can't I get the, like, maybe they do, but I feel like maybe in the culture of their training, they're better preparing the physician for, look, this is above you. Some of this is out of your control, and you do the best you can. And the patient has to show up and be all in too. What are they doing at home? But what I've noticed in dentistry is like, we show up with a cape, we are going to fix it. We are going to make,
Mhm.
and when I first started in the airway journey, I don't know about you, but boy, I mean, I've changed how I practice a lot.
Yeah, no.
I
I
used to think I'm going to fix everything and
Yeah. And I can
my
do it. And I can
I
do it. I have
right.
it. And then it's
It's
like,
like then you're
shit.
humbled. Shit.
Yeah. You're like, oh crap, there's way more to this than I thought.
Yeah. So it's like there's more to this. It's more complex, but I do love your spiritual component of this. And I am, you and I have talked about this, a spiritual person, and I do believe sometimes it's a very complex symphony, our life, right?
Hmm.
How many
Hmm.
times have you just serendipitously had things happen and you're like, if this wouldn't have happened, then this wouldn't have, if I wouldn't have had this, contrast or difficult time in my life, I wouldn't, and I didn't suffer or have, well, I guess suffering's very
No, this
subjective.
AI thing is exactly what you're talking about. I feel like I've suffered. I remember laying in bed 10 years ago when apps and stuff were coming out going, why isn't this app talking to this app? And why isn't this? I mean, and I wanted to pay somebody to fix it because I just wanted to go through my day and have shit fly to where it needed to go. And that just, I mean, I literally for 2 years felt like I was going insane. And then I finally let it go. But now I feel like that discomfort has inspired me to I wrote down all these scribbled notes and I kept them. And then I gave them to this engineer. I'm like, make this happen for me. But
That
had
is
I not gone through that discomfort, had I not had the sleep disorder breathing that I had growing up, I wouldn't have been ADD. I wouldn't have struggled through school. I wouldn't have had this obsessiveness about different things. So I wouldn't be having this and helping people.
right. So it's like, you know what? you know, sometimes the universe has this whole beautiful laid out plan for us, and what we're going through really is. I'm trying to explain that to my oldest son right now.
Oh,
He graduated from college in May, but he's
oh,
experiencing life, right?
yeah, yeah.
And it's humbling, and you do start to really realize, wow, I need to be open, I need to be curious and humble, and there are people put in my path for a reason, and
Hmm.
be curious about it. Why is this
Be
person?
curious.
Be curious.
Yeah, yeah.
And because it just leads to a lot of interesting, beautiful things, really.
Yeah. You have to try to think, I'm meant to be where I am right now for a reason.
Yes. You're right where you should be. You're
Right where I should.
not behind. I think that's a panic too. Like, oh, I should be in a different place than I am right now. No, you
Mhm.
shouldn't. You are right where you're supposed to be.
That's a good reminder today. Yeah, yeah.
You're right where you're supposed to be. And, just keep moving forward. Well, I'm excited to hear about what your AI is doing. Keep us all posted. And I would love to
Sure.
beta test that because I'm a Plod fan. I just
Yeah.
bought a second Plod because my associate and I, we have a lot of new patient exams at the same time, and we were like, we realized we're fighting over the plot. I'm like, okay, we can't have
Mhm.
that. So we got another plot for Christmas for ourselves, and I love it. PLAUD for those listening, wondering what the
Mhm.
heck this thing is. It is fantastic. I love it. Um, but we'll have to get that research article too that you were talking about
Yeah.
comparing slower expansion and MARPE and rapid.
Yeah.
I think there's just it's an exciting time, wouldn't you say?
It's very exciting. And even just a few years ago, I thought I knew what I needed to know. I'm like, "Oh, expanders. If you have airway problems, you need to expand." And it's like, no, you learn more. And I was intimidated to get into tonsils and adenoids. I couldn't find an ENT to work with me. And then now I do, and I feel better. And now I'm going to try the rhino manometer. And there's so much. And you just have to be thirsty and excited and just take
And
it
like you
in.
said too, if you don't have the answers, that's okay.
Yeah.
Find someone that does. And that's just the collaboration. I don't do everything in my practice, but what I've done is find, I've found people like you, and I refer, if I'm not equipped to do something, but I'm going to find the person that I know is going to, take the
Hmm.
best care, have continuity of care, communicate well with me, for my patient's behalf. But, we've got gut health. That's a thing too.
Oh,
It's,
yeah.
I think what I've been humbled with, like I said, when I started, it was like, oh, I'm going to put this, habit corrector in, or I'm going to put this, expander in, and boom, all the symptoms are going to go away. And then you're humbled real quick. You see miracles in some people,
Yeah.
you do. But then
Yeah.
sometimes, okay, we got a
Yeah.
change here, but we didn't get a change here. And so you
Yeah.
learn quickly to not overpromise and underdeliver.
Hmm.
But
Yep. True.
that's when you start realizing just because the orthopedic, dental facial orthopedics may not have changed everything in the patient, and they still need other things. It's not this or that.
Hmm.
It's kind of the chicken and the egg.
Hmm.
Yes, they couldn't breathe well. They weren't functioning well as a kid. They weren't eating the right foods. They had allergies as a kid. They weren't breathing well through their nose. They developed craniofacial hiccups in their growth and development trajectory. Yes, we need to correct the ENT problem, but it's not just that.
Mm-mm.
You now have the dental facial orthopedics that you have to correct as well. So it's not one or the other, it's all of it. You do
Hmm.
need to correct, give them a better nasal volume, give them a better house for the tongue, make
Hmm.
that palate not so vaulted,
Hmm.
but also get to the ENT, eat a better diet,
Hmm.
less inflammatory. Even, I was talking to, Stanley Liu. I was talking to, uh, even when I had Sound Health, had them on talking about, the Sonu and all these different things. And they all were agreeing. You can structurally address the nose, and that's beneficial and needed. But sometimes you get a rebound or things come back, it's because we haven't dealt with the inflammation, right? So
Hmm.
there's stuff going on gut level,
Hmm.
gut brain connection, and all the inflammation and
Hmm.
congestion. So it's all of it. You don't
Hmm.
just say, see, there's inflammation. That's the problem. Well, it's inflammation and it's structure
Yep.
and it's gut health and
Yep.
it's, nutritional deficits, right?
Hmm.
So we just keep chugging, right, Jackie?
And one reveals the next. Like, yeah.
It's like a rabbit hole for sure, but we don't give up. We just keep going
No.
and collaborating and learning from each other. And in 5 years, we'll be practicing it even differently than we are now. And
Hmm.
that's,
And
well,
sharing like this and your whole ASAP, like that's how you develop protocols that are collaborative and tested. Like you're talking, okay, so let's say you have a sinus infection and that's from a gut health thing. Well, then you're going to mouth breathe. And if you mouth breathe, you're going to make this worse. And if you're mouth breathing, then you're going to have the narrow palate. And then, so you clear up the inflammation, you still have the narrow palate and that stuff to deal with. So one reveals the other. Well, did it start with just the gut health or was it adenoids and tonsils? Like y- y-
It's all
talking about and sharing
intertwined.
cases, yeah,
Yeah.
you go, oh, I didn't think about that order.
Exactly.
Yeah,
And that's something too, Karen Parker Davidson. She's got some interesting stuff. Ask her about her gut health, the gut axis and the stuff with the gut, the nose, and the brain relationship. Super interesting stuff she's got. It's interesting. She's another person I'm honored to know, smart cookie. Thanks for being with me, friend,
yeah, thank
today.
you, friend.
I really love having you on here. And and we'll have you back, I'm sure, as things are unraveling with your AI. I would love to
Yeah.
even talk more about that. That's fantastic. And any information, like as things change for both of us, let's just keep having conversations. But I'm going to ask you the three
Okay.
questions before you and Blaze go enjoy your day. Your man. Okay. Three questions. Ready? One. Are you a sweet or savory kind of girl?
Both.
Good
So
answer.
if I had to grab one, it's usually sweets, but then I want that savory right after.
That's so funny. I kind of have to end with something. I don't like to end on sweet. I
No,
like
me either.
sweet, but I
Yeah.
want to end on savory. And that's funny. I'm the same
Yeah.
way. What's your favorite sweet and what's your favorite savory?
Um, Sweet would probably be, I'm always like, I want ice cream, but cake's a second, and it's vanilla. I'm not a chocolate girl. Um, does popcorn count as savory?
I think so, unless
That's
it's
just more
kettle
salt.
corn, then that would be sweet. But
Oh
it's
yeah, yeah,
like,
yeah. No.
but like regular popcorn, that's sort of, it's salty, savory, I'd say.
Yeah, so if I've had too much ice cream, then I need some salt. So I grab the
Uh-huh.
popcorn.
It's a
So it's usually ice cream than popcorn.
good strategy there. That sounds like our next get together. Okay. And then what is the last song that you listened to?
Jelly Roll. What's the one I'm Not Alone?
Mm,
I think it's that one. I love that touches me. I love that song. When he was going through his drug
yeah.
addiction. Is that the right? Jelly Roll. Sorry.
Yeah. Yeah, I know what you're I know you know. I love his voice. I know who you're
Yeah.
talking about. That's a good one. And what is your favorite way to unwind?
Snuggle on the couch with my man and my dogs.
Oh, that does sound good. That sounds fantastic. Well, and that might be what you're going to go do now. So I'll
Nah,
let
it's
you.
too early.
Okay. I was going to let you get at it, but all right. Well, thank you. Thanks for being on. And I appreciate you, friend. And thank you, listener, for listening. I hope you can walk away today with some more interesting information or knowledge to share with others. And um, I'll have a lot of what we talked about and in the links and how you can find Dr. Jackie Demko and maybe have her share her expertise with you and your family.
Thank you.
Thanks, everybody. See you next time. This podcast would not be possible without the inspiration of my dad, Daniel Becker, and creative direction and editing from the very talented Jason and Dane Becker, Ben, Lydia, and Judah Walker. To stay connected and keep the conversation going, be sure to subscribe to our podcast and visit our website at asappathway.com. And please remember, the information in this podcast is for educational purposes only. It's not intended to be used as medical advice or to replace your healthcare provider's diagnosis or recommendations.